Hello, everybody. Welcome to this week's Infection Control Matters. It's Martin here, and today I'm going to be joined by Giovanni-Battista Fucini, doctor working in Germany. And he and a large group have just published a very nice review called Sinks in Patient Rooms in the ICU Associated with Higher Rates of Hospital-Acquired Infections, a retrospective analysis. So we're going to have a discussion about that. So thank you very much for joining me, Giovanni. I really appreciate you spending the time.
Thank you for inviting me.
Okay, now we've done a couple of discussions on sinks in the past, and they are still a very hot topic, despite being probably highlighted back in the 1970s as being an issue. But they've come back to the fore. So what prompted this piece of work, if you wouldn't mind talking through how you started going down this line and what made you think, because I've never seen a paper like this one before, to be honest.
Yeah, I have to say my education is basically I was an anesthesiologist, and I worked a long time in intensive care, and I moved to infection prevention and control in the last 2 years. So for me, it was kind of a new, not completely new, but I had to discover this whole field of research from new, this association between hospital water and infections and so on, especially for the intensive care. And I found it incredibly interesting. So, and I started reading about it, and because also we are like in the project, we are trying to make some new suggestions and guidelines how to build future ICUs so that they are like optimized to prevent infections. And the big topic about this is how do we have to plan water systems? Do we need sinks in the patient rooms, and are they really needed, and where should it be positioned, and so on? And so I dived in this whole huge amount of literature, and of course you find out that there is a lot of information about contamination of water, that sinks are contaminated by multi-resistant organisms, MDRO, and from all kinds of, especially gram-negative bacteria. And there are a lot of information about the fact that they can be the cause of outbreaks, or the reservoir for outbreaks. In this, but the main problem for me was, okay, we know that if there is an outbreak, we have to look at the water. We know that the water can be contaminated, and there are also very nice papers who show how the possible infection pathways, I say not infection, but like transmission pathways, could be. And but then the main problem for me was to ask, okay, but we know that they can be a cause for outbreaks, but what do we do in the normal time? So is it really so relevant, like that we need to make a suggestion for general purposes when we say, okay, we need really to suggest to avoiding having sinks in patient rooms for all ICUs, basically? Is it really so relevant, let's say, in an endemic situation? So trying to and so we have in Germany this very good surveillance system, this network of hospitals which sends us. I'm working in Charité in Berlin, and we are the center of this network because all the hospitals are sending us their information about hospital-acquired infections.
Could I ask you just to explain exactly what that is, because we have listeners from all over the world, and this sounds like a very good system.
Yeah, that's called KISS, this Krankenhaus. It's a hospital in German, an infection surveillance system, and it's kind of it's a network. Like all the hospitals are in contact with us, and there are some rules how they have to collect information about their own, and also it's voluntary.
Voluntary, okay.
The hospitals who want to participate, they can, and then they receive from us some rules how they have to collect information about their infections, especially in the intensive care, but also there are some other rules for infections by patients after stem cell transplantation in the oncohematology and newborns, and there are also some other rules. And they can choose, every hospital can choose, okay, which kind of infections do I want to make surveillance about, and then they collect this information and send them to us, so that we actually have this overview, and we have the most important thing, we have the contact with these hospitals, and we are talking about for the group that is making making infection surveillance in intensive care, we have a group that's 1,500 intensive care units. It's a big number.
I mean, do you have an idea of what proportion of hospitals take part? Is it 50%, 60%, 70%?
Of all the intensive cares in Germany, you mean?
Yeah.
I don't know how many. What's the? But I don't know if it's 60% or 70% of all hospitals in Germany. This I have to admit. But still, 1,500 is a lot of intensive care use, a lot of beds, a lot of patients every year. So this is the system, very easily explained. But the main point is that I think we have this huge amount of data, and we send all of them an online survey asking them a lot of information about their intensive care structure, like how many rooms they have, how many single rooms, multi-bed rooms, and how many nurse stations, all this kind of stuff. And one of the questions was about sinks, if they have a sink in the patient room or not. So that at the end, 600 intensive care units answered this survey and gave us information about if they had sinks in patients' rooms or not. And then we matched this information with the infections numbers that they submitted in the last years. And these, at the end, they were not like 600, they were a bit less, they were 150, because some of those who took part to the survey didn't submit infections information. So we were 552, I think.
Yeah, but still a good number, 550.
Yeah, still a good number. And this about this 550 intensive care, we had both the information if they have a sink in patient directly inside the patient room, or if they don't, and how many infections they submitted. I mean, they had like we took a range of year like 2017 to 2020. Mm-hmm. We stopped 2020 because 2021 through COVID we had a lot of intensive care units we didn't send information and had to stop the surveillance. So it was kind of the data were not that clean anymore, and still we made the survey 2021. Assuming that, if they didn't have a sink in 2021, they didn't have it neither in 2017. Because
I don't think much building work was going on at that time.
we know that at that time could be that some, but actually we also asked them if they were going through big renovations in the last 5 years, and only a very small part of them did. So that's the information about the sinks didn't change that much. Also in the time we collected information about infections. So. And this was the purpose of this. I mean, there are a lot of limitations. We cannot know if these infections were occurring during an outbreak, for example, or if there's so we don't have microbiological test sampling from the water, from the sinks, so that we cannot exactly connect the pathogens to the infections. But it was just to have an overview, and the results we had is very interesting, I think. Of course, there are much less intensive care units that don't have sinks than the most of them, at least in Germany, the most of them have sinks in patient rooms. Was all 80 from this group of 450 was 80 ICUs were in the no sink group. We called it like that. And the other 470 did have sinks in the patient rooms. But still, the good thing is that the epidemiological data about the length of stay of patients, number of patients treated, patient days were similar. So although the numbers were different, but they were comparable. Interestingly, these intensive care units without sinks in patients' room were a bit newer. So that we can think there is kind of a movement in that direction. This probably is new ICUs. Something from this experience we read in the literature is going to be accepted, right? Like a prevention measure.
I mean, it's interesting. So if you were building a new ICU, in your guideline in Germany, would it say don't put a sink in a room, or would it say to put a sink in the room? Because in the UK, it currently says put a sink for every bed, and we don't think that's necessarily correct now.
Actually, in our guidelines, we will say that try to avoid it, to have it directly in patient rooms. I mean, this a thing that will. I am actually also in the commission. We are supporting the building of a new hospital close to the Charity, very new big center for heart surgery, and there was a big discussion about this because we thought, there is the possibility of building this brand new ICUs, and we would like to have to not to have sinks in the rooms. But the other hand, nurses and people who are used to work with sinks in rooms, they really like start how should we do it? How should we wash patients? Where should we put our wastewater away? And actually, this is exactly the point. You shouldn't
put the
wastewater in the sinks.
That's exactly the point. That is the point.
That is the point, and but this is difficult to make it acceptable for people. So you have to find a solution that is actually acceptable, that is good for infection prevention. At the same time, it also doesn't disrupt completely the process of care in the usual way.
Now we hopped on a bit. Could you talk about the results, because you and I know them, but
sorry.
we got ahead of ourselves.
Exactly. This is all. The whole point is that at the end we had this comparing the numbers we had that for the in cares with sinks, there was a 1.24 incidence risk rate, like 24% higher risk for patients to get an hospital-acquired infections during their stay, and this was significant, and it was significant for the whole, because in this system for intensive care, we make surveillance of three group of infection. There's pneumonia, bloodstream infections, and urinary tract infections. And that's so from these three group of infections, we had a higher risk for all the infections together, for from bloodstream infection and for urinary tract infections. We have also a higher risk for pneumonia, but it was not significant. And then we said, okay, let's say we know that the most studied microorganisms associated with water-related infections, or we suppose that it's water-related, are Pseudomonas aeruginosa. What about there is the most biggest body of literature. And so we took only the infections which were associated with Pseudomonas aeruginosa, and we made the same comparison, and we found out that there was also a higher risk. This was 1.27 incidence risk rate, but it was not significant for Pseudomonas aeruginosa, but it was significant for pneumonia with Pseudomonas aeruginosa. We only looked at pneumonia.
Okay.
We suppose it was the number were a bit different because there is the whole number of infections through Pseudomonas aeruginosa is not that big, so it could be not powered enough to be reach significance. But still interesting that from the infections of Pseudomonas aeruginosa, especially pneumonia is significant, because pneumonia is also most common infections caused by Pseudomonas aeruginosa. So if we have relevant risk there, it's important. So we made also a multivariate analysis, because we said, okay, there are also many other factors who can influence infections. Now we have to see, okay, sinks is one of the factors we are looking. And through multivariate analysis, we could find that actually sinks stayed as independent risk factors together with the type of ICU. Like we have accordingly to which direction, which specialization the ICU is. So we have different numbers. We have higher or smaller risk for infection for patients, which also kind of to expect it, because bigger ICUs are probably also located in bigger hospitals and treat also most difficult cases.
Yeah.
And the length of stay is, of course, also dependently associated with the risk of infections, the use of invasive ventilation, and the use of urinary catheter, which is also, we know that the use of devices is, of course, a risk factor for the development of infections. But interesting that close to these very understandable risk factors, we have also a relevant role of sinks in our analysis. So,
interesting, a really interesting piece of work, because you didn't find any difference between putting filters on sinks. So chances are it's maybe not the actual water coming into the sink; it's maybe splashed from the sink, which is interesting. But also, I wondered about. You've got Pseudomonas and you've got all infections, but including the gram-positive infections. And if you just stripped out gram-positives and just did all gram-negatives, I wonder if that would be interesting as well. Because, there's quite a lot of other gram-negative outbreaks that are related to sink splashes. That would be an interesting thing to do.
Actually, we did it. We did this analysis. We put together infections through Pseudomonas aeruginosa, Klebsiella pneumonia, and Enterobacter as the groups. We couldn't find so clear, so interesting results as we had for Pseudomonas aeruginosa, so that we didn't we decided not to publish it.
Okay, but was there a tendency for them to be higher in the nose? There
was a tendency, but it was not significant.
Not significant.
Always due to probably due always the same problem is that the single group of infections are too small numbers. So this was a bit
I was just wondering about bulking all gram negatives together in one group. The other thing I want to ask you is, people are worried about when they take sinks out. Well, what about Clostridium difficile infections? So did you have you any data on that you could actually compare C. diff infections between the sink and the non-sink group that would help calm people's fears about we can't take the sink out, even though they probably don't use it for hand hygiene anyway? As you mentioned, the Mathers Group paper that shows only 4% of activity at a hand sink in an ITU is hand hygiene anyway. So,
yeah, that's an interesting point. We didn't did this analysis. The main problem is that we don't. I told you we are on the ECUs. We are surveying pneumonia, urinary tract infections, and primary bloodstream infections. So it's Clostridium difficile is not really. But we also have some of the hospitals also make the surveillance for Clostridium difficile infections. We should just find out how many of the ICUs that took part of the surveys also does this kind of surveillance, and then make this.
It'd just be interesting because that's often what people come up with. Yeah. The other thing is, I was just thinking. Then you've got ICUs with water and some without, and the nurses are saying we don't want it without. But actually, a nice study will be to do a qualitative piece of work with the nurses working in the ICUs without the sinks in the rooms, and ask them how they go about working. Because they must have found solutions to that, what they do with patient wash water, or do they go to wipes or something like that? Or were they just presented with a room with no sink in it and they just adapt naturally anyway? And because taking something away from somebody is always a lot more difficult than actually not giving to them in the first place, I suppose.
That's true. Yeah, there is a lot I have some idea. The whole point is that we are trying to, and for formulating our suggestions, not for this kind of guidelines we are formulating for new ICUs. Find the point, what do people need the sink for? How do they use it? So that we can probably find the best solution now. And then, interestingly, you came out, why do we have sinks in the first place in the patient's room? Everything came from the importance of having a hand hygiene spot, to promote hand hygiene. And then now we have, this was a long time ago, and now... We are not suggesting anymore to wash hands, only in some very few situations. We are saying you have to use alcohol drops, and then so actually you don't need water.
It's rare, isn't it? Yes, it is rare that you would need water.
It's rare. It's when we say for Clostridium difficile, for example. Well, in Germany at least, there is only there is this or when your hands are really soiled.
Yeah, sure.
And then. But this not the normal situation. And then on the other hand, there is also, and then the interesting thing is that still the sinks are felt like a clean spot. But then, especially if you suggest them to use for this, the point. I heard the podcast had the Mr. Garvey in your podcast a couple of and I've been following his work, very interesting work in last times, and he said this, and I said, washing hands is actually not a clean activity. This is soiling the sink. So we should, and that's, but this, and then there is the point of washing patients, which of course you need water to wash patients, but still there are also other possibilities. Now there are at least the idea of scrubbing them with impregnated clothes, and that's been. We are not sure if it really prevents health-acquired infections. There are some data who suggest yes, some others suggest maybe. We don't know, but we probably have to find out the right product and the right concentration still, whatever. But there are alternatives, and this is the main point, that if we have alternatives, we can find a way of working without sinks, or maybe without having sinks directly in the patient's room, but having them close, like in the anteroom, or in the corridor. No,
it's going to have to be working with the staff, isn't it, and give them a range of alternatives, and then let them choose, and then they're more likely to do it rather than you say that's what you're going to do. That won't work.
And I think the most important thing is that we really separate these two use of sinks. That's the one use of taking clean water that we bring to the patients, clean them, to wash feet, whatever. And we have sinks where we just discard wastewater. And this is the main problem that we see in our ICUs still, is these two activities often happens at the same spot. And it's incredible how now on that's really nobody thinks. I mean, you wouldn't never take something out of a trash bin and then put it. You go and you take clean water from the sink where you just discard the solid water.
What is also interesting is when you go in to fill the bowl to wash the patient, the nurse doesn't hold the bowl in midair. They put the bowl in the sink and let it fill, so therefore contaminating the bottom of the bowl with whatever is in the sink, which you then put on the patient's bedside table. I saw Mike Weinring does a nice video on how that happens, and it's not very nice, really.
Yeah, we've been making also a small observational study on the same on two ICUs at in our hospital, and we have been observing exactly this use of the sink in the room, and we saw that they are used pretty a lot, but from all observations, most of the half of them they were used to discard things. Discard water or the clean.
It is a waste disposal area after all, isn't it?
The waste disposal area. And then the way the hand washing was 5% of the time. I mean, we made total of 16 hours. They were observing the people working there, and so a very small amount.
Are you writing that one up?
Maybe we are connected, and because we made also a survey among personnel in the intensive care, asking them if they need the sink and what for, and if they in other aspects of the intensive care structure, just to have this feedback from people who actually work there, and then observing them, and we will put together this data. I'm planning to write it also at some point.
When you get time.
But actually, the most my wish would be to make this kind of study we have been making now with this retrospective analysis, to try to make it prospective, like that we can filter out also outbreaks, and we really focus on the normal situation, like on the endemic situation, like say, because we always see we have this whole information that things are dangerous comes out from the reaction to a situation, an outbreaks or so, that somehow came out probably through some bad practice, and then reacting to them, like putting out the sinks or putting filters, then made the situation better. But we need to know, do we really have to start avoiding this, like having no sinks in patients' room at all, like without even before, so to prevent the outbreak. And to justify this, we need to know if they're really a basic risk factor before the problem starts. And then,
I think that's what you've shown, haven't you? I think that's what you've shown with this piece of work. That I know you've got caveats, but it does show
exactly. It does. This is the big step for me. I mean, I would like to have to collect this kind of data prospectively, maybe in a smaller group of ICUs, and as you said, also to observe how people can work without sinks, so that we really have even better data probably about this.
Well, I've really enjoyed the chat. Thank you very much, and I really appreciate you giving me the time to have a chat about
thank
this.
you for having me again.
Okay, great pleasure. Thank you very much indeed, Giovanni, and
bye.
Everybody else, we'll catch you again on the next episode of Infection Control Matters. Thank you. Bye-bye.